Hello, everyone. Welcome, welcome. I see there's a few more people jumping on, so hold tight. We'll get started in just a minute or so. Thank you for joining. Welcome, everyone. Still a few people. I'm seeing the numbers going up, so we'll just get started in just a moment. So hold tight. Thank you for joining us. Okay, hello, welcome everyone. Welcome to the Link Center Shared Learning Groups. We're so excited to have you with us all today. My name is Stacy Nonamaker. I am with the NASD's team. I'm one of the partners of the Link Center. You will meet some of the other partners throughout our time together today, so we'll have them introduce themselves. By way of describing myself, I am a middle-aged white woman with straight brown hair, about shoulder length. I have glasses on, and I'm wearing a white shirt with blue or black polka dots today. I'm going to go over a few housekeeping things to get those out of the way before we dive into all the good stuff we have planned for you. We do have live captioning and ASL interpreters present today. This session will be recorded, and the recording and transcript will be shared with attendees. The PowerPoint and documents we review today will also be shared with everyone via email. We welcome you to revisit the content yourself, and please share it with colleagues and others that you think may be interested in this work. Attendees cannot see the name of other attendees, and all attendees are muted. Please use the chat function to communicate with other attendees and hosts in this webinar, and you can do that by clicking on the chat at the bottom of your screen. Please be aware that your name will appear in the chat if you make a comment, and you are able to change your display name by clicking those three dots next to your name and selecting rename. We will have representatives from the Link Center watching the chat and responding throughout the session today. But if you would like to submit a question or comment privately to the hosts and panelists, you can do that by clicking on the Q&A function at the bottom of your screen. Following this webinar, you will receive an email with the material we reviewed today, the recording, and a transcript, as well as an evaluation that we ask you to please take a moment of your time. We know you're busy, but if you could complete that and let us know about your experience with today's shared learning group, we really do take that feedback into consideration. So thinking about the topic today, we're with one another for about an hour and a half, and we don't really have time to do a deep dive into the topic, but we are looking to start the conversation about how to get you the tools, information, and resources related to the topic of transition. And we'll talk more in just a moment about how we're defining transition. But we identify that depending on your experience, some of what we talk about may be triggering or hard. So we really encourage you to take care of you. And please let us know in the chat if there's anything we can do to change the words we use as we are meeting today. Also, I want to emphasize the shared in the shared learning group, meaning we're really looking to be engaging with you all and welcome all sorts of participation throughout this meeting. So some of you may desire to actively engage in the chat, Q&A, come off mute, come off camera, and some of you may just desire to listen in and witness, and we welcome all of that in this community. We are so very thrilled to be introducing you, if you haven't already been introduced, to the Link Center website. So there's our our handle for the website and the QR code. We're really excited. It's the website is in its infancy, but we're hoping to continue to pull some great resources and information together for you and get that up there. Spotlight some news, upcoming events for you all. So please take a moment, check out the website. We'd really love your feedback. If you're checking it out while we're together today, feel free to pop some thoughts in the chat. If not, at the end of today's session, we'll have an email. You can email us, or you can also contact us right on the website. All right, so talking about the shared learning groups, between today and tomorrow, we'll be hosting 4 shared learning groups. We already hosted one for DSPs, and we're having this one with clinical professionals. Tomorrow, we'll be facilitating a group for people with lived experiences and another for families. All of the information in the 4 presentations really is the same. We're tailoring it a bit for the audience. But really the topic and the information resources are really the same across the board. This presentation is a collaboration among the Link Center partners, including people with lived experience, researchers, and people who work on policy issues. And it bears repeating because people always ask, even though I've already said it, we will record and transcribe today's meeting. And that means we'll write down all the words that are said during the meeting, and the materials will be emailed to you after the meeting. So we encourage you to share anything that we share with you after the meeting. You'll see the slide again later, but again, this is really embracing the shared part of our time together. And we're asking you all, as you're listening to the information and really looking at the things that we're sharing with you about supporting someone through a transition from a hospital to community, what are some of your experiences that you want to share? What are some of your go-to resources, training, websites, just places you get information around this topic? Please feel free to share that. Really, at the Link Center, we're looking to elevate work and also find places where there are gaps and places that we could take for action as a group. So I've noticed some people are already putting their name in the chat and doing some introductions. That's great. It's always good to know who's joining us. So please feel free to say hello in the chat. We'll spend some time really talking about what we mean when we say supporting someone through a transition. We'll take some time to share some of the things that we've been digging up by way of resources and information related to transition. And then we'll lead you all through a group exercise to really focus on getting your good ideas and pulling your experience and things that you all have been thinking about when you're thinking about supporting someone through a transition. Really, there's 2 goals or intents of doing these shared learning group. And one is to do exactly as I described, to share with you what we think and folks that are part of the Link Center think is a really important topic. How do we better support someone through a transition? And also share with you the resources that we've identified from other people who have been thinking about supporting folks through a transition. And then the second part of the intent, or the goal, if you will, with shared learning groups is really to learn what you think about supporting someone, to learn about your experiences, and identify what resources and information you all have in your back pocket that we may not know about. Okay. Here's a lot of words, but I think it really is important for us to talk through this to set the stage for transition and what we'll talk about today. Transitioning from an institutional setting to a community-based setting, or from a congregate community-based setting to an individual community-based setting, is a time of critical importance in people with IDD's lives. Not only does it represent a time of disruption and uncertainty in people with IDD's lives, how the household is established lays the foundation for people with IDD's long-term stability and security to ensure that they're able to stay in that home. So I think that's a really powerful quote. And today we're going to present info from the perspective of what you as a clinical professional can push for, can make happen, can prepare for. We have some other things in the works outside of this shared learning group around the topic of transition, like pulling together focus groups of hospital personnel to help us understand from their perspective and experiences of treating and discharging people with co-occurring conditions. What are they facing? What are the barriers? What are the things that we could be doing better partners in this work? We hope that through those focus groups and these shared learning groups, that as the Link Center, we will be able to develop strategies, resources, and information for people to have better, more successful transitions from acute settings to the community. So to talk more about that, we worked with one of our steering committee members, Dr. Kim Jackson. Dr. Jackson was a family medicine physician in Pueblo, Colorado until 2012, when symptoms related to Ehlers-Danlos syndrome forced her to leave practice. With her slowly progressing health conditions and resulting disability, she began working with the Colorado Cross Disability Coalition, CCDC, in 2013 on disability rights in healthcare. Dr. Jackson is the appointed chair of the Colorado Prescription Drug Affordability Advisory Council, which works with the Colorado Prescription Drug Affordability Board to make medications more affordable. She also serves on and chairs multiple committees and boards for Colorado Medicaid and is secretary of the board for CCDC. Dr. Jackson identifies as autistic and also lives with post-traumatic stress disorder, in part due to trauma around accessing healthcare for her multiple chronic health conditions and disabilities. Unfortunately, Kim cannot join us for this gathering today. And she says she's sorry. Something did come up today. She spent many hours working with us to develop this content, and I am going to do my best to represent her message about her experience and her thoughts on transition. And when Dr. Jackson is able, we really hope that she'll record this for us. Her words are very powerful. So Kim has imparted on us that when it comes to transition, two really critical things at the outset of talking about this. One is we have to do this right, because if not, we cause more harm to people. Things like post-traumatic stress disorder and things like people being reluctant to seek medical help when they do indeed need it. The second thing that Kim really has imparted on us is that we also have to figure this out together. Whether we work in the hospital, we're community providers, we're individuals, we're primary care physicians or other supporters, this work cannot be done in silos. So let's take a step back. We do some ground setting with our shared learning group. First is certainly this meeting will be talking about people transitioning from acute settings to community settings. Some people have experienced trauma, and that makes it hard to recover and move forward. Again, please take care of yourself. Next, take care of yourself and do what's necessary for your comfort and care. We should be gentle with ourselves and each other because this is hard work to do. We celebrate that we all are individuals from different backgrounds. We celebrate that we have shared experiences to learn from, and we know that we are each unique with our own experiences in the world. Finally, we listen and share with open minds and kindness. We do not judge or blame others for what they share. So what does it mean to transition? The way that Kim has really unpacked or defined transition is change from one form or type to another. In this case, from being hospitalized to living in the community. We know it can be short-term or long-term, and it's a process for people. And like that quote said, transitions often represent a major shift or milestone in one's life, and the stakes may be high. Kim has really done a great job of talking through with us that transition is a process. It can be ongoing for people, and that leaving the hospital or returning to the community can be a big deal, a major shift for someone. but that there's also opportunity in a transition like that, a chance to set up services that somebody may not have had before going into the hospital so that they can have the support to live successfully in the community. And we'll talk a little bit about setting up services that someone may need so that they don't get lost in follow-up or they're not admitted to the hospital again. So when we say hospital and community, when we use the words from a hospital, we mean acute medical care, mental health, long-term institutional facility, and generally it means more restrictions for the person and less or limited autonomy. What we hear from some people is that, this is a time when they're feeling very in a schedule and the day is very routine and structured. And many folks that we're talking about with IDD, brain injury, and other co-occurring conditions may prefer that structure, but their executive functioning limitations may make it difficult for them to do this on their own at home. So things like medications are provided at the right time in the hospital. We don't have to worry about that, right? Medical appointments or doctors, that's all done in the hospital and doesn't require scheduling, remembering, getting there. All of those things that may be challenging for someone when they're living in the community. And when we say community today, we mean apartment condos, houses, supported living, group homes, halfway houses. And generally, these are less supervised settings, less restrictions, where someone is responsible for their choices and decisions. And, as we talked a lot about with Kim, just really less structured. And that alone can make it harder to figure out a schedule. Kim shared where we've heard from people that meal planning, for example, is taken care of in the hospital, right? And people may not know how to or have access to the same foods or same diet, especially if medical factors are involved. When in the community, people need to schedule their own medical appointments, follow-ups, remembering the appointment, getting to the appointment. So when it comes to community living, Kim talked a lot about how many people are low income, and maintaining some of these things that are necessary for treatment and care, from physical to mental health well-being, takes resources and money. So think about it. People may not be able to drive or have access to mass transit, transportation. They may not be able to afford those medications that were prescribed. They may live in low-income areas where there's food deserts, crime. Faith-based resources might be limited. Things like LGBTQ, religious communities. And many, many people with co-occurring conditions have a history of significant trauma, and they just may simply lack trust in the system and in professionals that they should be seeing while they're in the community. So our goals really should be, when we're thinking about transition, of course, we should be putting our eggs in the prevention basket and meeting people's basic needs and not so basic needs in the community, and keeping them out of the hospitals when they don't need to be there. But if someone ends up in the hospital, the goal shifts and is more focused on getting someone to a place where they can get back to the community. So the focus for this meeting is how to make this transition as successful as possible. And so the goal really is, as Kim has reminded us, full integration. And what does that mean to the person? What is the person's definition of what that is? Not ours. And Kim also talks a lot about supporting the whole person, not just the medical problem, not just the mental health diagnosis or presentation, that quote primary presentation, that primary diagnosis, but the whole person. And if someone needs supported living services when they're in the community, still trying to find and aiming for the least restrictive environment is critical. So some more goals that we should have in mind when we're thinking about transition, again, speaking to the holistic piece, is meeting an individual's physical, mental, social, spiritual health needs while living in the community, reducing the need for readmission. What does that mean? What does that look like? And just ultimately keeping people out of the hospital if they don't need to be there. I love when Kim would talk about transition being a process. It's not a checklist, and that it's dynamic for most people. Goals need to be revisited and changes made if the person isn't satisfied with their situation. So Kim impressed on us always that the way that we define whether or not a transition is successful is that we need to ask the person what they want, what they need, how they define that. It's patient-centered or person-centered, and the outcome varies. It's individualized, right? And we need to, what are those metrics, markers, milestone? What does it look like that someone has achieved what they define as a successful transition for themselves? And knowing that sooner rather than later is critical. And I love when Kim would talk about considering accountability generally, but specific to measuring success. Who is responsible for making sure the transition to the community was successful? And who is going to keep making sure the transition stays successful? So in the chat, we'd really love to hear from you all as supporters. What does a successful transition look like for you in your role? So we already mentioned a few, right? We've thrown some around. I'm sure that some are churning for you, but we're just curious, in your role, what would a successful transition look like for somebody that you support? I'm going to just let you think about that. Put your thoughts in the chat if you feel like it. But we'll sort of go on and talk a little bit more about some of the things that Kim talked about for herself, for others, that are critical to a successful transition. Kim really frames this around talking about large scale and small scale systems and resources needed in the community. So let's talk about large scale first. So large scale things are like payments for getting the treatment and care and supports and services that you need, having access to the medical providers and care coordination, having access to mental health treatment, having an income, having social support programs, and transportation is so critical and vital to it all. Some things that Kim notes that is really important here is when it comes to SSDI, that there are high denial rates for first-time applicants, and that most people qualify but have been denied. So that is a process that people have to go through when they're thinking about income and money, which is, an important piece when we talk about resources. When we talk about Medicare, thinking about the lifetime hospitalization limits, people may not be able to stay inpatient even when necessary. And we had a lot of conversations with Kim around transportation and how critical it is to access and access to resources and access to things in their community that are critical to getting their needs met and keeping folks out of hospitals. Most areas lack usable and accessible mass transportation. Many people that we're talking about do not drive. Even people who have Medicaid waivers and have access to like a transportation service, sometimes it's really difficult, whether it's you are responsible for scheduling it. Sometimes it's not reliable. Sometimes there's long waits to accessing transportation. And I've been sort of keeping my eye to the side on the chat and notice that transportation has come up, housing has come up. So you're all on the same page as Kim as well. Kim also talked a lot about the importance of what she called small scale systems and resources. And I love that she used the words, the grassroots approach to support. Community resources vary greatly. It's what's available in someone's community or what they can get to, right? Small scale supports are hugely necessary. Who can give someone rides? Do they have someone to call? Like if they have a minor emergency, do they have peer supports, or can they connect with someone like over the phone or via text when there's minor problems? Work is so critical and so important to help with someone's sense of worth. And that does not mean that someone has to work 40 hours a week and in a paid position. That could be volunteer. That's important too. People could be going to school. It's what gives someone purpose and meaning. Local communities can be hugely impactful, whether it's a local disability community, support groups, and other communities. Kim talked a lot about how important it was to her to be connected to social media groups and to the steering committee, the Link Center steering committee, because those things provide a great source of support to people. One way to accomplish this, and some of you may be familiar with the life course tools. There's a tool called Exploring the Life Domains, and I'll put a link in the chat soon when I'm done talking here in a couple slides. But the tool really helps someone think through life domains and where, when someone's feeling good, they need to think about what resources they have and what resources they don't have if and when they really need to access those things. So again, it'll be a resource that I'll pop in the chat if you're not familiar with it, but one that really helps to think about those small scale resources and systems that Kim talks about. So today we're going to focus on what you can do. And a successful transition means that everyone needs to work together, but there's a few things we want to acknowledge. We first want to acknowledge that you may not have influence over others who can also make a transition successful, like people in the emergency department, right? You may not always have options or community providers who are willing and knowledgeable enough to support someone. This is certainly the reality and can pose a barrier to transition. And there may be people who may have been in a hospital for a long time and may not know another home or place to live. And that means that our work as supporters is trying to help them redefine what home is for them. And then finally, a lack of accountability at all levels leads to a lack of responsibility for helping the person. And those are Kim's words, and I think really, really powerful for us to really take away and think about what are our roles as supporters in this process of transition. So Kim says, consider a grassroots or small system approach for people. There are too many dysfunctional systems, and there's only so much you can do in your role. And Kim continues to remind us that transition is a process. So hopefully today we're going to give you some tools, some resources, and things to think about as you support someone who may be transitioning. So here's where I get to turn it over to my colleague and partner in the Link Center, Wendy Morris. Wendy, please.
Thank you very much, Stacy. Well, this has been a great start to our conversation, and I want to thank everybody for being here today. We know there are lots of things you could be doing to spend your time, and we're glad that you chose to be here with us. So my name is Wendy Morris. I'm with the National Association of State Mental Health Program Directors. But for context, I am a nurse by training and have worked early in my career as a bedside nurse in medical facility. I have worked in the emergency department, and I have worked in psychiatric hospitals. So I bring some of that perspective. To visualize, I am a middle-aged white woman with long gray hair, which I'm wearing down today. I have on a white shirt with big bright orange and lime green flowers, and I have the Link Center logo as my background. Next slide. I will also say, again, we're going to have some chat prompts, so please use the chat when we get to those so that we can continue to have shared learning, and another reminder to take care of yourself. So I wanted to start by sharing a resource. It's, as you can see, it's called Things That Will Help People Leave the Hospital. And this was published by the Center for Addiction and Mental Health out of Canada, and is one of a whole host of resources that they offer. Stacy's put for you in the chat the link to this particular easy to read summary, which is great for individuals, and then also the larger body of work. But when I first started to pull this together, this was a summary that I went to get me started. And next slide. So we know communication is key to so many things, and developing a transition plan is certainly one of those things. As I'm sure you know, there are so many people involved in this process. They need to be talking to each other, sharing the information that they're gathering, what they're learning, and working together. The team at the hospital also needs to be sure that they're talking to the person who's transitioning, as well as any family supporters or clinical professionals that they're working with. And that care team also needs to be very careful to communicate with the person in a way that works best for them. Next slide. So one thing you can do is help the team at the hospital really understand what might work best for the person if they're struggling with that. So there might be accommodations or supports that you know have worked well that you could share. You might need to remind them, use plain language, please avoid the hospital and medical jargon and all the acronyms, to use visual supports when they can, pictures, charts, pamphlets, any hands-on activities that might help with learning, return demonstrations, any technology, videos, apps, websites. Make sure that if a person needs an assistive device, that they have access to that during any kind of teaching that's being done around discharge, and that they're allowed to have a support person with them if they would like to do that. The other thing I just want to remind you as clinical professionals, and you may already have experienced this. As I said, I'm a nurse by training, and I have been in the hospital on a number of occasions to support my mother. And she always wants to tell everybody I'm a nurse, but I have tried to tell her that sometimes that can be very off-putting to the staff. Other staff really embrace it, and they want me to kind of go ahead and take over. So the staff at the hospital might do that. I think the biggest problem is when they will talk around the person and talk directly to you or directly to family instead of to the person. And so the best we can, we want to encourage them to talk directly to the person when they're asking questions or sharing information. And if they continue to struggle with that, to act as a liaison, maybe repeat things back to the person or turn to the person and ask the question if the staff are not doing that. So role model what works, and then role model talking directly. Next slide. Other communication tips for that team at the hospital, and this kind of works really both ways, is we want to be patient and give grace to one another. We need them to be patient and give grace to the individual. May need to remind them, ask one question at a time, allow the person to gather their thoughts and to answer the question, especially if they have an assistive device or struggle to find the words they want to use. Ask that they use discussion prompts to check for understanding, to engage the person in the process and not just talk at them. Also, we want to be paying attention to nonverbals. Does a person seem confused or maybe disinterested? Are there other ways we could try to get the information to be interesting or so they understand it? And the same thing with the staff. Do the staff appear to be impatient? Do they appear to be in a rush? Are they getting frustrated? Do we need to ask if it would be better for them to come back at a different time when they can give the time that's needed for the discussion? Next slide. So we know an important thing to doing really good transition planning is the hospital team needs to know as much about the person and what they need as possible. So they're going to ask a lot of questions. We know different people on the team are going to ask different questions, and quite frankly, they will often ask the same question, which can be very frustrating when you have 3 or 4 people asking the same question. But there are lots of reasons for this, and as clinical professionals, you've probably been in the same position. Sometimes it's about continuity and just seeing, are we getting the same answers every time we ask the question? It might be that there's some new information to be gleaned. Maybe the person has changed their mind, or they forgot to say something earlier when they talked to somebody else that they are sharing now. So it's a good opportunity for the person to provide additional or just information, or just to reiterate what they've said before. Again, we want to be sure we're giving the hospital team grace as well. Next slide. So the other thing that's really important is that the hospital team may not get around to asking some questions that will allow the person to share some information that's really important, or for you to share information that's really important. So it's important that a person assert themselves, and that we as clinical professionals assert ourselves to make sure the team at the hospital has the critical information that they need. So even if they don't ask particular questions, we want to be sure that we are sharing important tidbits to help that be successful, what some preferences are, what some needs are. Honesty is absolutely the best policy. In some of our prep meetings for the shared learning group, another one of our steering committee members, Monica, really honed in on this, that it's so important for everybody on both sides to be honest. The person who is transitioning needs to be honest about what they need, what they want, what they prefer, what's important. And it's equally important that the team at the hospital doesn't try to sugarcoat or try to convince somebody to do something by withholding information, or making it sound a little nicer than maybe it is. And then the last point here is just to be sure we're not waiting until the day a person is being discharged from the hospital to ask some important questions, or to let the team know they're really not ready. Next slide. So obviously the person who's transitioning, it's critical that they're involved in this process, and the conversations and the decisions, as well as their family, their caregivers should be involved. And we want to be sure that the hospital team is asking the person directly and not working around them. We also, again, have family and others involved. But when this is done right, the transition process is really person-centered. It's really about the person, not the team, and it should be an empowering experience for that individual. Next slide. We got to remember that caregivers need training and support too. So while the person who's transitioning will be getting lots of education about what care they need, their follow-up that's needed, we want to be sure that the hospital team has asked the person who is going to support or care for them when they are discharged, so that they can be educated too. And this is another one of those questions. If the hospital doesn't ask it, we need to be sure that we're offering that information, that detail is not overlooked. Next slide. It's important to have a written plan when leaving the hospital, so it can be referred back to. This is pretty standard, but if you can, it would be good to have the written plan ahead of any education that's provided on discharge, so that the person can review it and see what kinds of questions they might have, maybe take some notes, highlight some things. Again, we want to be sure that we encourage the person and any supporters to speak up if there's additional information they need. Can you print something off for me? Do you have a pamphlet? Is there additional information, a website or something that I can go to learn more about this? And if the person doesn't feel prepared, or you don't believe that they're ready to be discharged from the hospital, we want to be sure we say that, so that other steps can be taken to have that be successful. Next slide. So this is my first chat prompt, and that is, what other tips might you offer about communication? We're going to talk more about transition and what we need to have in that plan. But as far as communication, other tips you might offer to your colleagues, to the hospital team, to the individual. And if you want to go ahead and put those in the chat. Excuse me. All right. While folks are gearing up to that, we can go ahead to the next slide. So Stacy did touch on this. As Kim is always saying, transition is a process, right? So when I think about discharge, I really think about it. It's an event. It's that moment when you leave the hospital and you go to the community, right? You cross that threshold of the door. And but transition is a much longer process, and that planning can happen in some cases even before you're hospitalized, which we'll talk about near the end. It can certainly happen during hospitalization, and then it will continue after hospitalization, as has been said, to be sure that that's a successful process. Next slide. So hospitals, of course, are required to do a discharge plan. They're required by their licensing. They're required by accrediting boards like CARF or Joint Commission. It has to start the day of admission, but it's very specific to the reason for hospitalization. So if the person has been admitted for chest pain, it'll be about how to take care of their heart. If they're there for broken leg, it's going to be, how to take care of the cast or other things that might have been done as treatment. It's going to include, where's the person going to go? Back to the home from where they came, or are they going someplace new? Are they going to need any further care, medication, equipment, appointments? It should list all of those things. It really should be a roadmap, right, for transition out of hospital. But often we know those are computer generated. So if the person has been there, as I said, maybe for chest pain, there's going to be a button that gets pushed and it's going to spit everything out about heart care. So it may say something on there about watching your cholesterol or low cholesterol diet, but maybe your lab values didn't show high cholesterol. So it may include things that aren't pertinent to the person. And it very well is going to leave out a lot of stuff that is pertinent to the person. So it's not person-centered. And then it's really we all know it's part of the person's medical record. So it's a critical part of the transition plan, but by all means, not all inclusive. Next slide. So when we talk about transition planning, there's just a few things to think about beforehand. One, we know that the longer the stay in the hospital, the more challenging the transition is going to be for everybody, not just the planning, but the transition itself. And that even a short stay can be very traumatizing for a person. Even a few hours in the emergency room, a person might undergo some very uncomfortable treatments for their injury or illness. If they've been admitted, they're going to experience a loss of control. They're going to have limited options for food. They might have a roommate who keeps the room really hot or puts something on the TV that they find irritating. They're going to be woken up at night to get their vital signs and to have blood drawn. If they're in a psychiatric hospital, even worse, they're going to have their person and all of their belongings searched. They're going to have a number of things confiscated: shoelaces, belts, their phone, maybe their communication device. All very traumatizing. And then you're in an unfamiliar environment. It's an unfamiliar routine. You're being separated from your support system, your loved ones, maybe your pets, different comfort items. And it can even be something simple like, I missed my favorite TV show because I was stuck in the ER. All these things can make it very uncomfortable. Next slide. So again, transition can take a lot of time. If a person's been in the hospital for an extended period, that planning can take many days, sometimes weeks, depending on how complex the needs are. If possible, if a person's going to a new home and they have an opportunity to visit, that can be very helpful. To meet some of the new staff they'll be working with, or new supporters, can also be helpful. I apologize, I have a tickle in my throat. It's also important to know that once they get discharged to a new home, that's a process too to get used to that. Next slide. All right, so let's talk for a few minutes about what goes in a transition plan. Now, this first slide is a very general information that would be in any standard, should be, and if it's not, we should ask for it. Very standard information for a discharge plan. So again, this is going to be specific to the person's illness or injury that caused that hospitalization. What care is going to be needed after discharge? Are there precautions that we need to take to prevent relapse or complications? If it's something like a broken leg, they're going to talk about what if there's a fever or there's red streaks or other things that might indicate there's an infection. What signs or symptoms might warrant a call to the doctor or urgent care? There should be a list of medications. Why is the person taking them? How are they to be taken? And when? With food, without food, in the morning, at night? Are there common side effects like nausea or headache or drowsiness? Is there anything that you should call the doctor about, like if you get a rash? And then it would also list things like the healthcare team. Who is on your healthcare team and how do you contact them and when? So medical doctor, therapist, DSP, peer support. And then a list of any follow-up appointments, anybody and everybody that you're supposed to go see. What is the date, the time, and the location? Next slide. Now, these are some things that would be in a more person-centered transition plan and that the hospital might not think about, and we may need to ask them about and be sure that there's a plan in place. And some of this was Stacy touched on. Are there things that happened while you were in the hospital that made life a little bit easier, or things that you'd really like to be able to continue to have access to in the community? Was there a certain structure, routine, something about the schedule, meal times, or time you got up, or time you went to certain therapies, or assistance with certain activities? She talked about meal prep, meal planning, but also maybe help with your medications. Maybe that's not something you'd had before. And then again, how can all that be replicated in your new home? Social support is another important one. How are you going to get your prescription medications? Not just this first time, but when you need a refill in 30 days. Does the person need assistance taking that medication or just reminders? And how about follow-up appointments? How are they going to get there? Does somebody need to go with them? So on and so forth. Next slide. Housing is a big one, and I think a few people put that in the chat. There are some really important questions, and some of these really might require that the person have some privacy when they're answering them, especially if they feel unsafe in their home or there are things they need to share that they really can't do in front of the person they live with or the person that's supporting them. So it might be a time to ask them, would they like some privacy when the hospital is asking these questions? But we want to know whether they're going back to the home where they came from or to a new placement. Do they like that home? Does it have everything they need? Do they feel like it's an appropriate place? Is it safe, comfortable, provide privacy? Do they like the community or the neighborhood? Is this an urban area or a suburban rural area? Is that a place they like to live? Transportation is another thing that came up in the chat. How are they going to get to their daily activities or things they'd like to do on a routine basis? Go to the activity center, go shopping, go to church. What about special events? Maybe there's a movie, a concert, a sporting event, a birthday party. How will they get to those things? Is there public transportation? And if so, do they need somebody to go with them for that to work? Next slide. So second, this is the next chat. It's what's not on that list that you think is really important. We tried to cover a lot of the basics, and no list will be inclusive of all people, but there are some big things that we left out. We would love for you to put those in the chat for us so we can include them in the future. All right, next slide. So these are some examples of some transition planning tools. The first one is really geared towards discharge from the medical hospital. It's pretty comprehensive. The second one I found to be a bit more person-centered. It's very easy to populate on the computer, which I appreciated. The third one is really geared more towards transitioning to independence with healthcare as a person transitions from adolescence to adulthood, but still has a lot of really good examples on it. And I think between these three, they would give you really good examples of how to kind of build your own and see what might be included for different individuals that you work with. Next slide. I wanted to talk for just a minute about psychiatric advance directives. I think most people know about advance directives for medical care. If you don't want to be put on life support, or maybe you don't want CPR if your heart was to stop, I think most people understand that that's available, but there are also psychiatric advance directives that are less known. And that's a legal tool that allows a person with a mental illness to state the preferences for treatment for that mental illness in advance of a hospitalization or a crisis. If you're not familiar with the PAD, the SMI advisor link we have here gives a kind of a basic tutorial. What is it? Why might a person want one? And really the best time to develop these kinds of plans is when a person is feeling well. So not something you'd want to do while they were in the hospital, but something that you'd want to do once they're discharged, but before subsequent hospitalization. Next slide. This link it gives details for every single state. So I'm here in the state of Kentucky. I can open it up. I can click on Kentucky. It tells me what the laws are here. I can access a form that I can fill out with help, and then take steps to have that become a legalized document. So the next time I'm hospitalized, I can provide that to the hospital. So we don't have time to look through it today, but it should be in the link, and we would encourage you to look through that on your own. Next slide. So a little bit more about planning ahead, or what to do between hospitalizations or ahead of a hospitalization to be prepared. One is just to develop a crisis plan. So help a person think about what are their triggers, the things that make them feel not well, especially in the mental health arena. And what are some strategies that are helpful for them to feel more calm or to feel better? The first link here, Managing Triggers Tools, is a tool we went over in some detail in January during our shared learning group on trauma. And the second one, What to Do When I Don't Feel Okay, is a tool we went over in our shared learning group on crisis last fall. You can watch both of those shared learning groups. They're available on the website, or if you just want to look at the tools, they're here for you and in the chat. Next slide. The other thing to do to kind of plan ahead to make a hospitalization and the transition a little bit easier is to make a list of help the person make a list of what they're going to need while they're in the hospital. This first link is basic to what you would need in a medical hospital, but we'll want to be sure that person-specific items are added. Are there certain comfort items like a special pillow or blanket, fidget or sensory objects? Do we need extra batteries or chargers for assistive devices or iPads, that type of thing? Does the person need headphones, earplugs, music, something to block all the chaos of the hospital out? Do they need sunglasses or a hat to block that fluorescent lighting that could be really irritating to people? I'm sure there are other things that we could add to this. Next slide. And so that's our next chat prompt, actually, is there a tool that you use for transition planning that you could recommend to others? We would love to see it, even if it's just one you use in your organization or you personally have developed. If you would be willing to share that with us, we would love to see it so we can share with others. Next slide. I want to talk just for a minute about guardianship. Unfortunately, sometimes hospitals try to tell people that they need to be under guardianship in order to be discharged. And this happens a little more frequently when that discharge follows a very long hospitalization, or the person has very complex needs, or there's some disagreement or pushback about from the person or people that support them where the hospital wants them to go. So it's a way for the hospital to kind of speed up that discharge process. Guardianship, as I'm sure most of you know, is when another person is given the power to make important decisions for an individual. But if the hospital were to suggest that guardianship was needed, it's really important that that person call protection advocacy to talk that through and make sure they understand what their rights are before allowing that to happen. Next slide. Again, once a person has a guardian, and there's all kinds of guardians, it doesn't cover everything, every type of guardianship, but it might cover medical decisions, it might cover money, you know, there's a variety of things, but they could lose a lot of ability to make legal decisions. And unless somebody truly, truly cannot make decisions for themselves, they should not be put under guardianship. We have a link here for alternatives to guardianship, just for your interest. Next slide. Next, the next couple slides are really about just on supporting transition and some different systems that are in place. Next slide. Just a couple little factoids. One, to make sure everybody knows that there has been a change in the law and that when people are in the hospital for a medical reason, their direct support staff can stay with them, and that Medicaid waiver can still pay for that service. That really makes it a lot easier for people to have someone with them that knows them to support them in the hospital. So that's very important. The next bullet on here is that the Center for Medicare Services recently provided information that allows professionals who support a person to get paid to consult with each other on behalf of the person. And that's, as we've been talking about, really important for person-centered supports. Next slide. Money follows the person. I'm sure a lot of you are familiar with this. I think I even noticed in the chat there's somebody who literally does this work on there who could probably talk about it better than I. But Money Follows the Person is available in 43 states in the District of Columbia, so it may or may not be available in your state. But this is a national demonstration program where states can structure their grants. Everybody can do it a little bit differently, but generally it provides funding to support the development of services, tools, and processes to improve access to home and community-based service, so the HCBS, to Medicaid eligible beneficiaries who need long-term services and supports. It's only available after somebody has been in an institution for a certain period of time, and it's not available for all institutions. It really can't be used if a person's been in a psych hospital, a freestanding psych hospital. And again, each state is a little different, but generally, if they're discharged from medical hospital, nursing home, and ICF, it can be really helpful. And what you see on the slide here are some different ways that states have used that. So using transition coordinators to collaborate with the hospital, ensuring timely supports in the community, providing one-time transition costs. So for all those kind of one-time things when a person just gets a household, those house-related costs, offering training on person-centered planning and enhanced supports for up to a year after discharge, which is it's a long time, right? That's a good start to help make sure that there's some stability. So if you don't know a lot about Money Follows a Person, you might want to contact or look up your Medicaid office in your state. And with that, I'm going to turn it over to Brenda from NASHA, the National Association of State Head Injury Administrators, and Dr. Deb Pinos to do our group exercise.
Great. Thanks, Wendy.
Hi there. Is Dr. Pinos joining
I
us?
am.
Oh,
I
okay,
am.
sorry.
Can you hear me and see me?
I can hear you. I don't see you though. There you are. Okay, great.
Great. So should we introduce ourselves?
Yes, I will follow your lead.
Okay, so I am Dr. Deb Pinos, and it is a pleasure to be here. I am a psychiatrist. I'm a middle-aged woman with short dark hair. I'm wearing my AirPods in my ear so I can hear this webinar, and I'm wearing a black shirt, and I have the Link Center background on. And I am a clinical consultant to the Link Center through NASDs, and I also work for NASHBID, which is the National Association of State Mental Health Program Directors. And it's a pleasure to be here to help facilitate the group exercise. And I'll turn it back over to you for you to introduce yourself.
All right, great. Hi, everyone. I'm Rebecca Wolfkiel, and I'm the Executive Director of the National Association of State Head Injury Administrators. and our organization supports state brain injury programs across the country. I am a middle-aged white woman with long brown hair, and I am wearing a colorful blue and red and yellow kind of floral shirt today with a Link Center background as well. So delighted to be here with you all today and have learned so much already from this rich discussion.
Great. All right. So what we want to do now is put out some thought exercises for people. We're going to describe, we can go to the next slide. We're going to describe a case, and we're going to ask for you to include information in the chat, and Rebecca and I will kind of read the chat and try and foster the virtual dialogue. So here's the scenario that we put together for you. And by the way, just to help you understand, we did a similar scenario for the other shared learning groups to get perspectives from others like direct support professionals, and we'll get that tomorrow with families and individuals with living experience. So the scenario is that you consult weekly at a psychiatric hospital. Dwayne has been in and out of that hospital many times over the past 2 years. They are diagnosed with schizoaffective disorder and had a brain injury in college about 5 years ago. Dwayne does not always take their medications, and when they are told that they are transitioning out of the hospital to go back to their family home, they get stressed and nervous, and they either shut down and won't come out of their room, or they become angry and will become aggressive, pushing staff and other patients. How can you help them feel safe and better prepared to transition out of the hospital and back to their home? Think about the resources and points that we've talked about today. So we'll just hopefully see the chat for people to type their thoughts in, or raise your hand if you'd like to come off camera. Come on camera and off mute, or just off mute.
One point that I found interesting about this case study was that the repeated entry into the hospital. I know we had some discussion about length of stay, but someone that is frequently in and out, I think also has some unique needs.
Yeah, I think that's a really good point. I was thinking about the same, and it seems like, the hospital is in this situation sort of the pass through, but it has to be part of the whole community plan, because Dwayne will otherwise be left dealing with all more transitions, hard transitions, if it's not all integrated as one big plan for care.
Yes, that makes sense. Yes, I think, William, I was thinking the same thing. What is the fear of going home? What are the specific fears and challenges that Dwayne's facing that puts them in such a state of reaction at the thought of going home?
Yeah, because William says that being able to help them understand why they have that fear of the home seems to be a flashpoint.
Mhm.
And I would think that that would be a really good point of focus to understand. And Stacy says, has a trusted person sat down with Dwayne to understand what he thinks he needs to leave the hospital, and how does he measure success? I think, your thoughts about that, Rebecca?
Well, I don't know that we know. I think we need to get Dwayne needs some trusted support, I think, to help him feel more comfortable and to share what specifically his concerns are with going home so that they can be addressed.
Yeah, and I would say from my perspective, I think a lot of times we as clinicians, if we're not kind of attuned to these issues, like for people with head injury and serious mental illness and developmental disabilities and things like that, that the understanding how challenging a transition is, we may minimize it, and we may just think like, that we may not really see what the issue is. And also Dwayne, I don't know, I think Dwayne should, it'd be great if somebody could sit with Dwayne, but so that also assumes Dwayne is even able to articulate it themselves. And
That's right.
sometimes I think people with complex needs can't really put their finger on what is stressing them out.
Well, I think that's a great point. Sometimes we can't understand why, the irrational feelings are coming into place, especially with these challenges that Dwayne has. Good point, Craig. Medication noncompliance is not helping his behaviors. That's absolutely right. And I think Dwayne needs obviously some support when he's back in the community to keep him on track with his medication, keep him feeling engaged in the community and at home.
And I would want to understand, what is the barrier to that medication adherence? Like, are there side effects that people haven't addressed? Is it just the complexity of taking a medicine at a certain time each day, the scheduling of it, what are I think we need to drill down and not just assume med adherence is just one thing. It can be so many things and for so many reasons. And so trying to understand what would support that continuity would be really critical.
Well, and I think that's, to that point, he had a brain injury 5 years ago. So oftentimes short-term memory is a challenge. And so maybe understanding if he has some long-term side effects from the injury, including memory, perhaps he could be put on a schedule so that he is taking his medication at the same time every day, or set reminders for him to help with compliance.
Yeah, and that head injury may get lost because of the schizoaffective disorder. People might forget that they've got two issues that they're dealing with, or more.
I am seeing that there are two raised hands, and they can certainly go ahead and unmute themselves if you would like to jump in.
Hi, this is Dr. Monroy. Can you hear me?
Yes, we can.
Okay. I was going to say a technique that we use successfully is storytelling, and having the individual at whatever level is appropriate for them tell the story around what happy times, happy memories, things they've enjoyed about the house. And conversely, once we have a lot of talking about what their preferences and likes and those kinds of things, we also gently ask them about challenges. And then we can develop a specific list of each challenge, how it can be addressed. So if they're connected with a support, for example. So I'll give you a case example. We just had a young lady who didn't want to come out of the hospital because when she was home of the work schedule of her mother, she was often alone, and it scared her. And she would hear noises and the whole thing. So being able to identify a direct support person for her and a resource network for her that she could talk to while her mom was working, it eased her significant anxiety and worry, and was able to transition pretty well. So, we use this sense of story and just letting them talk and listen and give them. So with this, how would this feel for you if, we could have this support to not be there? So we focus on those things. And the baseline for the story we have found to be successful because it is a gentle way of trying to do active listening and give them back, okay, we heard you said this. Can you tell me more? And in fact, tell me more is one of the most great things. Now, you have all brought up excellent points about where the person's level of functioning is and communication and what can be there. So there's a lot of different ways you have to accommodate and facilitate storytelling, but again, we try to do that as much as possible.
I love that idea of the narrative and storytelling. I think that's so gentle is the word that comes to mind, and person-centered, rather than, here's my list of questions and my, my form on my clipboard, and I got to get it all filled out because of my needs to have my documentation. And instead it's more, let me understand who you are. That's really great. Thank you for sharing that.
I was thinking the same thing, the focus on person-centeredness, and that really is sort of the epitome of that type of planning and thought.
And then there were two things that came in the chat. One was from William. There's a great book called I Am Not Sick, I Don't Need Help, that outlines how to help people with learning to be okay with needing help. I think that's just one of our very hard things in life for all of us, is to accept help, and to realize that we're human and need help at times, and not wanting to burden people. So that sounds like a great book tip for us. And then Mary asks, does Dwayne and their family have supports in place at home, or are they thinking that he might want a different living situation? And that's another great question, because we don't want to assume that the current situation, clearly there's some dynamic going on about the stress of returning. It also makes me wonder if there's some trauma stuff going on that's triggering, and getting a better understanding of whether that environment is, so often environment can worsen people's reactivity for whatever reason. So thank you, Mary. That's a good question.
And I think we have another hand raised, Chai Porter. If you'd like to come off mute.
And I'm not seeing the hands, Becky, so it's great that you are. For some reason, I can't see them.
Raise my hand at all. Sorry.
Oh, well, maybe I'm not, Deborah.
Other thoughts about Dwayne's situation?
I do wonder, and obviously I have a predisposed to be thinking about head injury, but aside from the medication mismanagement, I do wonder what other challenges that the history of the injury is affecting Dwayne with, because oftentimes we do see these really challenging, complex cases, and we know there's a history of injury, and it just really completely complicates an already very challenging condition.
Well, what's also interesting to me is that this occurred in college, which means that Dwayne was in college. And that's often a time where we have early psychotic episodes. First episode psychosis can present, early in life. In young college kids, it's not that uncommon. So maybe there were multiple things going on at a critical place where brain development was still happening, even if it was beyond the age of 18. So how that affected so much of how Dwayne adapts to circumstances. So Dwayne is now 5 years post-college injury.
I'm thinking about substance misuse as well, since that often can lead to injuries in college, and so much more information needed about Dwayne's history.
Right. And then this aggressiveness and pushing staff, I think there's another challenge is that once we get into seeing somebody with aggressive behavior, sometimes our countertransference, our fears, our difficulty working with an aggressive person can limit how much we sit down and take time to listen, because it can be hard to talk to somebody who's manifesting anger with aggression. And so, sort of settling, doing whatever you can to settle the aggression so that you can get to know Dwayne as a person is really going to be important.
Mhm.
And there may also be family members or support professionals who know Dwayne better and who can provide more information if Dwayne's willing to allow it, unless Dwayne has a guardian that might need to allow it.
Stacy says, I would want to know how the hospital staff, Dwayne and his family prepare for the transitions that have not been successful. Oh, that's a great point, Stacy. We can learn from things that are not successful as they are they using a transition plan? Something that could be concrete for Dwayne. I was thinking the same thing, Stacy, when Wendy was presenting earlier about the importance of having a written plan that goes home with someone, because often the guardian may not be with the individual, or maybe again with a brain injury or other cognitive challenges, they may forget. And it's really helpful to have that written guidance to be able to refer back to. But that's such a great point. Obviously, the transitions have not been successful to date. So why is that? What can we learn from that?
Yeah, and then sort of figuring out, have there been prior transitions that have been successful? Kind of the same question in reverse to try and see what did work and then what hasn't worked, to try and build as much success into the transition planning as possible. I think Stacy's adding to Kim's points about small scale resources that are critical when transitioning to the community. What is in place? What is not in place? Yeah, small scale resources, like is there some comforting object that could help Dwayne feel something to hold, a squeeze ball or some kind of object that gives Dwayne some comfort, a blanket. Sometimes that can help a lot, where it feels like there's some consistency between one setting and another. And they may benefit from peer support, right?
Absolutely.
Any other thoughts from our participants?
I thought transportation was a really critical piece that was discussed earlier that I don't know that we are always sort of thinking about when it comes to transition, or maybe not first or front of mind. But if someone is already going through a traumatic situation and then needs to take some type of noisy, loud public transportation home or back to, their residence, of course, that's also adding to the trauma. And so ensuring that someone has a solid transportation plan in place could be also very beneficial.
Yeah. And even just that, like a transportation issue can really, it might not be the setting that somebody's going to, it might just be the transportation to get there that can cause some of those challenges during that transition. So that's a really good point, Becky.
I believe William has his hand raised.
Yes.
Great. Please join our discussion, William.
I work in crisis services. I am the next step. Whenever people are coming out of institutional situations, I work with this a lot. And God bless the social workers and things that they're working with them in the institutional situations. But a lot of times they haven't been out on the street side. So the thing that I continually run into is someone coming out that they've got this amazing transition plan, but they don't have them hooked all the way in with a caseworker already to follow up with them, like a community caseworker, or being able to have them hooked up with appropriate communication. And a lot of times if they've been hospitalized for a long time, families not around. They're not in the picture. So they give them this amazing plan. Here, if you go do this, and it's like this big lump of paper they've got, and they don't have a phone, and they're going to a homeless shelter, and they're going to all these different places. And the thing that I've worked at in my area with, because we have a state hospital here, is like getting the social workers their information on how to get people a phone before they get discharged, how to make sure that we have a way as a community mental health center to make that initial contact to bridge the gap. Because with that, you get lost in the cracks within 2 or 3 days. So I mean, the transportation side, that's something you can teach someone on the outside, but just having that initial point of contact, we can set up all the appointments in the world for somebody, but if we don't have some way for the next person to make the contact with them, they get lost so fast. So
I think
a
that's such an
point.
important point.
Yes.
And we know from, suicide research, we know from research on people coming out of other transitions, like coming out of jails and prisons, like that handoff, that next step, that, follow up to make sure somebody got from point A to point B can really make a huge difference in terms of saving a life or helping somebody for, support more successful choices as they come out from a transition and they're, struggling a little bit with the new environment.
That concept of offering cell phones, though, to remain in touch with somebody seems so important, that link to and connectedness to help for that individual themselves. I think that's a really good idea. In the brain injury community, we have resource facilitation services that links up an individual with a care coordinator and helps them find resources. That it's in some states and some settings, but it feels as though this individual would benefit, and these individuals in this type of situation would benefit from a point of contact that was helping them navigate the resources available and continuing to check on them.
Right. And Stacy adds, we need to develop that transition action plan, not just what will happen, but who's doing it, what's going to happen, when and how. All those details that can be sorted out. Very important. It helps people anticipate and reduces anxiety and confusion. I think that's a really good point, Stacy.
I think William mentioning the homeless shelter is also, I'm surprised we hadn't brought that up earlier, frankly, but we don't know where Dwayne is coming from. He may not be going home. He may have to be transitioning back to a homeless shelter. And in that case, the hospital may seem like a more favorable place to stay.
Yeah. Yeah, I think we can't make assumptions that the next step is going to be an easier step or a more freeing step or liberal step. It can be more challenging in many ways. And that's where some of the stress could come in.
Particularly with someone with schizoaffective disorder, again, brain injury. I mean, they're having challenges living independently for sure.
Any other comments? We're coming close to the wrap-up time. I just want to make sure we've given everybody an opportunity to weigh in. Feel free to add comments to the chat or raise your hand. All right. I think this was a really good discussion. Becky, thanks for co-facilitating with me. And I think we will just give you an opportunity. Remember, the chat is still going, and any of your feedback that you think of as we're doing the closeout, please let us know. But in the meantime, also wanted to see if you have any other thoughts about go-to resources, trainings, websites, and places to get information about supporting someone through a transition from a hospital to the community. If you have any other ideas of resources that we should capitalize on and take advantage of to share further, things that you find helpful, please do let us know, similar to the one that came out of Canada. We're looking for any resources that people find helpful about information about transition. Then I want to remind you that, and thank you for participating in this shared learning group. Tomorrow we have the same topic, supporting someone through a transition. We have one for families, and then following a shared learning group on the same topic for individuals with living experience. And then on August 20th, please return. August 20th, we have a shared learning group for direct support professionals, another one for clinicians. And then the following day, we have one for families and for individuals, and really want to make sure that people come to those, weigh in. We are really excited about these shared learning groups as an opportunity to brainstorm together and learn from each other, and really build out further resources as we see that there are needs for them for the Link Center. And just again, to remind you that the Link Center is a live website. This is the QR code. You could hold your camera up to this and get to the link, or you can type in acl.gov/the Link Center, one word. And if you want to be in touch with any of the support team at NASDS about this work, the Link Center at nasds.org. NASDS is NASDDS.org. And they are the lead for the Link Center, although working with numerous partnerships, including the state injury, the head injury program groups that Becky represents, and others. Really, really appreciate people's participation, and please be in touch as needed. Also want to give a big shout out to Dr. Kimberly Jackson, who sits on the Link Center Steering Committee. Although she could not be here today, her input was incredibly invaluable, and we are grateful to her efforts to help build out the content for today's shared learning group and for tomorrow's, frankly. And really also want to thank, on behalf of the team, all of the partners at the Link Center for contributing to the preparation of and content for this meeting. It is truly, truly a team effort, and we're very grateful for everybody's partnership in helping this work go forward. And I think with that, I'll just turn it over to Stacy, and I think we'll close out.
Yes, and I echo that sentiment. Thank you so much for spending your time with us this afternoon. I did pop a link in the chat. If you would just take a moment to complete the survey about today's shared learning group, that would be great. Again, we do take all of that feedback as we're preparing for and thinking about additional shared learning groups and additional work for the Link Center. So thank you all so much for joining us, and we hope you have a great rest of your day.